Welcome to episode 2 of OrthTeam Unplugged. I'm Andy Thomas, and today I'm delighted to be talking with two expert radiologists. We have Dr. Andy Dunn and Dr. Subhasis Basu. Welcome, guys.
Thanks, Andy. Thanks for the opportunity.
Hi there.
So, Shub, if I start with you, so you and I have known each other for some years, and I would say you were the first person that would really introduce me to understanding radiology. But for the audience, just talk to me about what radiology is.
So radiology is a specialty in medicine that essentially involves working with imaging. So I always kind of suggest that it's almost like detective work. We use imaging where patients that come through clinics or hospitals will have some form of diagnostic test. And within radiology, there are multiple imaging modalities that we can utilize, whether it's taking simple x-rays, which is really good at looking at kind of bones and alignment of bones and joints. And then you can expand onto slightly more higher end cross-sectional imaging, such as CT and MRI, that a lot of people are used to when they say, I'm going for a scan. And with CT and MR, it's really good to look at some of the soft tissues in greater detail. We also have ultrasound as well, another imaging modality that uses sound waves to kind of look at various soft tissues within the body, and in our case, in the musculoskeletal system. So there's different imaging modalities that encompass radiology in terms of imaging.
So, Andy, what made you want to become a radiologist, and what do you have to do to become a radiologist?
Well, all radiologists would start out, obviously, with a medical degree, and that's the same internationally. All radiologists are initially doctors. And then, certainly in the UK, most radiologists have done some form of medical or surgical postgraduate training. It's a little bit different in the US, where you can go into radiology residency straight from doing your medical undergraduate course. And if I take my individual sort of path or route into radiology, I was interested in medicine. I did jobs in cardiology, lots of emergency medicine, and it was actually an error that led me into radiology. And I was inserting a particular type of line into a vein, and the line got dislodged, and to my horror, disappeared. And so I then, with an ashen white face, went into the radiology department and went up. Radiologists have historically been unapproachable. This is the sort of a traditional view. The junior doctor going in, having to beg for a scan. And I went to an interventional radiologist and told him what had happened. And I went with him and the patient, and he used an interventional technique, went into the vein. The line had found its way into a large vein not far from the heart, and he went in and with a grabbing device retrieved the line. I thought that was a pretty cool thing to do, and it also saved my bacon. So after that, and I've always been interested in anatomy. I've loved anatomy, and I've had interest in sort of biomechanics and sport. And so I decided to go into radiology, and within radiology found my although I've enjoyed all the aspects of my training, I went into musculoskeletal imaging. And most people who will the days of general radiologists, where you basically reported a bit of everything, they've kind of become less of a career path now. Generally, people go and subspecialize. And if you want to subspecialize, most people will do some form of fellowship. So you do your 4 years of radiology training, and then a final year, or sometimes a 6th year, you can go and do a fellowship. And so I spent my 6th year in Canada, in Toronto, doing a fellowship, and then came back to the UK and took up a consultant post.
Yeah, no, it's really interesting, and I'm sure that you're a lot more approachable than what the perception was previously. So, yeah, I'll take your words for that anyway. But I think it is interesting how things have changed. Like prior to starting this, we were talking about the transfer window, which has just happened now, and your name's synonymous with working with a lot of elite athletes. So, what is your role on a transfer deadline day? As a big football fan as I am, what's your role on that?
It is essentially being contactable and available to receive large amounts of imaging, which can be sent without any warning, and provide a report which is hopefully accurate but also appropriately worded. Within sports imaging, in particular when reporting transfers, it's the aim is to get an imaging review of the athlete, and we hope most of it is entirely normal. But there can be lots of minor abnormalities which are normal for that athlete or normal for that sport, and particularly normal for the age of the athlete as well. So a very minor defect in the cartilage of the knee in a 32-year-old footballer is essentially normal for that phase of that player's career. Whereas if you were signing a 16-year-old athlete and there was a cartilage defect, that would have more significance. So it's about wording and tempering the report based on the significance of those findings. If there are abnormal findings, then there are sometimes comments which have to be made, which can be very difficult to make, such as what is the probability that that abnormality might progress to something more serious, and over what time frame. And these are all discussions that are had with the club regarding contract negotiations, the duration of contract. So I have situations whereby you find abnormality on a scan in a joint, and the club might say, well, should we offer this player a 4-year contract? And sometimes you have to say, maybe just 12 months and see how it goes. So you sometimes have to step out of the sphere of being a medical imager, and you're actually trying, you're in a position where you have to give comment on things such as playing duration and contract length. The other thing which you have to do is be able to turn those reports around quite quickly, because there are deadlines, and as you say, deadline day, there's a rush to sign players, so lots of imaging is happening, lots and lots of people, they want the answer as soon as the player's off the scanner. So you have to be able to make those decisions and prepare those reports quite quickly.
So, Shub, with imaging, is it as literal as black and white when you're looking at something? That is that, or is there more interpretation that needs to be considered?
Yeah, that's a really important point, Andy. So there's nothing written in black and white to say you can only have one thing wrong at a time with anybody. And I think in my experience with imaging, for sure, and in musculoskeletal radiology as well, we find when we're interpreting scans that you can actually find a multitude of problems or areas of abnormalities, which, in my opinion, I think is very important for us to document in that report. I think what's really important, or more important rather, is clinicians, when they go back and see those patients with the radiology report in hand, that they can see the different abnormalities or pathologies that are highlighted by the radiologist, and then reassess, re-examine and correlate clinically. It's that old adage in radiology about correlating clinically with their signs and symptoms to see which of those potential abnormalities fits with the patient's presentation at that moment in time. It's also worth noting that with imaging, it's almost like a kind of spectrum over time of what's going on in a patient's shoulder or a patient's hip or a patient's knee. So you may find historical or established abnormalities and findings on the scan, which may not be relevant to that presentation or pertinent at that moment in time. With imaging, there's a whole host of things, and part of our job is to try and also account for what is causing those patients' symptoms, whether it's pain or disability or difficulties with range of motion, and then put that in our kind of interpretation of the scan findings. Sometimes it's not easy with one particular imaging modality, and therefore we may suggest as radiologists to consider a different imaging modality to help us as an adjunct to perhaps performing ultrasound first of all, and then maybe going on to MRI scanning or vice versa, because of the different opportunities that the imaging modalities provide. For example, with ultrasound, we may be able to perform dynamic scans and move the patient's limb or body or stress the available joint, etc. And that can often give us a bit of a heads up. So there's a multitude of things really that we can find on scans, but it doesn't always equate to being the active problem. And I'm always very keen to stress that to our patients, that I think our job is to be able to highlight that. And then, as we work in a multidisciplinary kind of format, our surgical colleagues and our medical colleagues can then evaluate that data, that information, and try and really nail down a diagnosis for the patient.
Yeah, I think it's really, you mentioned the MDT there. So that's one of the things which I think OrthTeam does really well. With the last pod we did was with Jim Kerss and John Rogers. So how does that work from an MDT perspective? Because I know it's an important part of your work.
Yeah, the SEM, Sports and Exercise Medicine (MDT), has been a really sort of exciting addition to the OrthTeam Centre, and it's a forum whereby every week the SEM doctors are able to sort of bring their cases which have either have imaging abnormalities or sometimes non-imaging abnormalities, which, for instance, the imaging does not necessarily fit with the clinical presentation, and discuss that in a sort of a relaxed forum with other colleagues, because it's not all about just finding the abnormality and saying, right, we need to do this. Sometimes imaging is performed when there is a clear clinical problem, but imaging doesn't give you the answer. So those discussions are actually as important as the ones where, yes, there is this tendon problem and this is how we're going to manage it. The other thing the MDT allows us to do is to feed into other specialties. So, for instance, when a pathology or an injury is getting to the stage whereby it needs to be considered for surgery, then a discussion can be had around which is the most appropriate surgical specialty or surgeon to refer to. And again, it's very helpful having multiple members of that group who can tap into their experience, and one person may not have been aware of a certain specialist who works with a particular problem, and that can be highlighted. It's another useful forum to discuss about image-guided interventions as well, and that's probably my most sort of common question is that I present the imaging, we talk about the findings, and then the question, well, is there any kind of injection or image-guided intervention which would be appropriate? And we can arrange that very quickly. Because we're not waiting for the referral to come from outside; it's being generated internally.
And we talk about interventions. There's new ones coming out all the time. There's various companies that they're promoting their different products. So how do you keep on top of these different interventions that are out there, and then how are you trying to pick which ones you think would be appropriate?
Yeah, I mean, it's really difficult. It can be very difficult and challenging. There's so many products out there. I think the very fact that there's so many products available or coming out suggests that there's no one thing or one size that fits all, and all patients are different. We have to manage patients, at merit to see exactly what their presentation is. Pain can be very subjective between patients, but also objective. There are lots of different pathways that can cause pain within the human body, and all these various products that are out there are probably trying to act on each and every one of those different pathways, and it can be difficult to almost pick the winner, if you like. I do work very closely with my surgeons and clinicians. It's one of the best parts about working in OrthTeam, that we have that multidisciplinary support, and quite often we get asked to inject what some of our surgical colleagues feel would be appropriate for that patient at that particular moment in time. We try to rely a lot on the evidence, on the evidence base, and also based on the kind of experience that some of our patients and our athletes and our clinicians have had with various products. And it's also worth saying that even if you try something and it's not worked, it's not always the end of the world. There's a potential to either repeat the same injection or consider something else. And you often find when you go through that kind of triaging, if you like, of the different products that are available, you find something that actually hits the spot and does well for the patient. And that's just a fact of life. So there's no one size that fits all. We try to heavily rely on evidence that's out there, speak to colleagues, not just within OrthTeam Centre, but with practitioners that have had experience in such products around the country and around the world. It's quite a small field of medicine in that scheme of things, and we do enjoy having those collaborations and conversations with other colleagues, and I think that's how we kind of try to do the best we can.
Yeah, I mean, there's a lot of parties involved in this, and communication is going to be key. So you've got your team, that you've got really experienced colleagues. How does the referrers, say the physiotherapists from either the sports teams or the private clinics, where do they come into the conversations that you're having in your MDT meetings?
So the multidisciplinary meetings are useful because, as you say, we kind of get all the various specialties involved that are involved in that particular athlete or in that patient's care. And we have conversations with all of them to kind of find out, what the problem is, how maybe some of the athletes or patients have been rehabbing, where they're struggling, and where we think there is scope to kind of improve. And all those conversations are almost like kind of put into that kind of pot, really. And we have those discussions to work out, is there a surgical solution to this? If there is, fine. But is there something that's maybe less invasive at this stage? And rather than jumping to an operation, can we do anything else which is kind of minimally invasive? And that's where we would come in as radiologists, perhaps, with our kind of image guided intervention, and think about some of the kind of therapies and products that we have, not forgetting also the rehabilitation side as well. So with kind of external referrers, we're always available for those conversations, even through MDT or even privately, email, phone, etc., to have those conversations with individuals to work out what might be the best thing for that particular patient. I think it's always nice and useful to have almost like a plan A and a plan B and a plan C, kind of knowing where you're going, whatever you use to treat, because if something doesn't work, you've got another fallback option. And I do like working with people that have that kind of mindset, because then you kind of feel like you're really invested in the patient. You want to do what's right for them. We may approach and do something that doesn't work initially, but then we know what we can do if it doesn't work. And having those conversations when I'm consenting patients, I find very useful, because I really like to get patients engaged in what I'm doing to them. I'm sticking a needle ultimately into them. I want to make them better. But we all know that sometimes what you inject doesn't always make those patients or those athletes better. And then there's something else that we can do. And I think patients do respect that. So that's kind of how I would approach, managing those kind of treatments and liaising with our colleagues, with physiotherapy practitioners, our primary care colleagues out in the community.
Yeah, I mean, it's a collaborative process. There's many people involved in it. Like for you, Andy, I'm sure you get WhatsApped a lot. That you mentioned the various different modalities of communication, which is great for people's accessibility. But how does someone end up seeing you? Like, is it they directly? I'm sure you do get messages constantly. You mentioned around the football. But how does someone end up seeing you at OrthTeam?
Well, there are a number of contact points, and often it does start with a WhatsApp message. And the issues that some of my referrers have, certainly in professional sport, is they're not at a desk or by a computer. They're out on a training pitch, and they've just seen someone, have an injury, and they've assessed it pitch side, and they're like, right, okay, we need a scan. And so in that situation, it'll be a WhatsApp to either myself, but also what's very important is our sports concierge service, which we have at the OrthTeam Centre. And that, since its inception, has made a huge difference to my life, in so much that if I'm not available, or if I don't get to see the message immediately, they can contact them, and they have access to the schedules. They can tell them when the MRI slots free and injection appointments free. And they will then feed into myself, and in some instances, because they're not medically trained, they get asked questions that they can't necessarily answer. They will contact me, call me, WhatsApp, and ask, are you able to do this? Is this appropriate for this scenario? So it's a very sort of symbiotic relationship. The physios learn from it. I learn from it, and our sports concierge staff, admin staff, learn from it. So every day they are, finding out, okay, yes, well, that injection perhaps isn't appropriate for that situation, and they can sometimes educate the physios and doctors referring in some instances. So it's a really good sort of route into the OrthTeam Centre. Obviously, there's direct email referrals. So sometimes we'll just get a referral that's emailed directly into the admin, who will then look at the MRI schedule and get them in as soon as possible. Another is just picking up the phone and calling. And I get quite a lot of calls, but sometimes, when you're busy, you sometimes find you're away from your phone, you're doing a procedure. And so generally it tends to be email and WhatsApp are the most common routes of referral into the OrthTeam Centre.
I mean, it's interesting. I'm sure you guys are slammed busy with various things, and you're massively in demand, because we can see that even for amateur athletes now, they request, you hear that terminology, I want a scan. So how do you manage your own lives in terms of like, how do you balance your life from dealing with all of this?
It's a good question. It's quite difficult, particularly at the moment, having had the just finished with the transfer window. It's difficult for it to not to become, a massive part of your life, because sport, unfortunately, rarely sleeps, and it's a 7-day activity. So you tend to find yourself working 7 days. And although work slows down at the weekend, there are still, after every sports fixture, if there are injuries, there are conversations, there are messages. And imaging centres are now scanning 7 days a week. The OrthTeam centre, we scan at least either a Saturday or Sunday. And from that will generate reporting, which we have a 48-hour turnaround on our reports. So everything has to be reported within that time frame. So, and generally speaking, professional sports imaging, I try to work to a turnaround of no more than 3 hours. So weekends, are frequently interrupted. But I think you have to find, as we were discussing earlier, you have to find time for yourself. And I do manage to get in a little bit of time to exercise, and obviously spend time with family. So, but it's certainly the sports imaging side of things. It's something you have to love to do. The day, I always say, the day when it comes in, a scan comes through, and I just like, I really can't, be bothered talking about that. That's the day to hang up my dictaphone, I think, and just say, look, this isn't right for me. But it's a labour of love, but it's one that I'm enjoying for the time being.
And I'm sure you will get requested. People will request a specific person to do a scan, particularly in sport, I would imagine. So how do you do it if you're on holiday then? How do you manage that?
I have got people who can cover when I'm away. So I've got the guys, my 4 other colleagues at OrthTeam Centre, my colleague Alpesh Mistry, who's on the same, and I say IT networks. I say that because IT is quite important with remote sports imaging, because a lot of the work I do is imaging performed at other imaging centres that's sent to me for reporting. And you have to have common databases or networks whereby that imaging can be stored but accessed remotely by other individuals. And so we have network associated storage, which all the scans that get sent into me get sent to, all the reports that I generate get sent to, because again, what's very important, if I'm on holiday and a scan is performed and there's a previous scan to compare it to, you need to have that previous report as well. And as an old colleague of mine always said, the most important X-ray is the last one in the packet, and that's actually quite true. If you're reporting a scan, if there's been something before, you need to have eyes on that, and you need to see what's been said about it before. If you're going to be able to say, okay, this has progressed, this has stayed the same. IT structure is crucial to an effective sports imaging practice. There are certain restrictions with systems which we call PACS, which stands for Picture Archive Communication System. This is a repository, a database where imaging is stored in a hospital environment. And quite often, clinics, imaging that's performed at remote clinics don't have that. And so you almost have to provide your own PACS. And so a busy sports radiologist will often have access to a database that they can populate and refer to. In some instances, the clinic itself can act as that. IT is important, as well as having people that you can rely on to provide the same service that you do when you're away.
Yeah, I think it's a really interesting point with technology. I know, Shub, you educate all over the world and you're up to speed, and you're looking into things like AI and new technologies. So how do you keep on top of technologies as well in terms of progressions with each of the imaging modalities?
Yeah, that's a really good point. I mean, first and foremost, I love my job. I think we all love our job, otherwise we wouldn't be doing it. And I think that does help with those challenges that we have, challenging moments through the careers when it can be very busy. There's a lot of stuff happening around education and technology, as we know. We're in a kind of era now where things are just expanding at such a fast rate. I actually got into radiology when the PAC system came in and it was all digitalized. And I wasn't a radiologist it wasn't a career that I was looking at anyway when I was at medical school, but it's kind of something that's developed. And it was the technology side of things that really got me going, really. Um, I attend lots of conferences and various meetings around the world. One such conference is called Radiology Society of North America, the RSNA. It's one of the biggest, I think it's the biggest medical conference in the world, encompassing all specialities. In its heyday, I think prior to the pandemic, we had about 60, 70,000 footfall at this center, which is typically held in Chicago in the kind of cold times of November, post kind of Thanksgiving. And it's one of those areas and conferences where we get to see and meet different vendors and different companies that are kind of showcasing some of their technology. That could be with ultrasound machines, that can be with CT and MRI scanners, but also AI. And certainly in the last several years, artificial intelligence has massively expanded and grown to have a much bigger footprint at these conference exhibition halls. And you just speak to these various companies, see what they have to offer, and then you try and work out whether what they have will be useful in your clinical practice and help with our patients. And I think it's already here. It's just about trying to work with these various companies and industry to do the best we can for our patients. But it's very exciting times, and I think that helps us to kind of stay kind of grounded, but also keep keep busy on our toes, because with everything that's happening around us, you have to kind of learn to evolve. And I always feel that if you're static and just do what you do, then yes, you may be content and happy, but you will fall behind. And I think with our speciality in particular, I think it's really important just to keep on moving, embrace the changes, evolve with what's coming, and it actually makes your job a lot more interesting as well.
Yeah, technology is so pivotal to the work that you guys do, and AI is used in every sentence almost now. There's massive usage of that terminology. But for imaging, it's quite ahead of other professions where it is being used already. So what's the latest from AI within your role?
Gosh, so I guess in my musculoskeletal practice, I've been involved in the utilization of artificial intelligence for things like fracture detection with X-rays. So patients that may have trauma will come in and have an X-ray. The artificial intelligence software can also interpret the imaging and then provide a report to say whether there is a fracture or not. Again, there's lots of different variations to these softwares. So once you start liaising with the companies and their researchers, you can actually tailor the software to work wonders for you. So if I said, look, can we look at something beyond fracture detection, maybe soft tissue abnormalities and things like that, swelling on such kind of imaging modalities like X-rays, they can pick those things up. So it highlights and it gives you another bit of support really to the reporting radiologist. When it comes to things like MRI scanning, there's software that can help to speed up the sequences that are acquired for patients when we're taking those scans. So actually now in the last kind of few years, we're using accelerated software that can help to speed up image acquisition, so we can get through more sequences for patients, which means we can get more patients through the door. But probably more importantly, from a patient comfort point of view, those scans don't take as long as they used to, once upon a time. So it's always difficult to lie still in a scanner when we ask you do not move while we take those scans, because if they do, then the images can get disturbed and they often need to be repeated. But as we've all, I'm sure, been in an MR scanner as patients, it can be very difficult to lie in a position where you might be in pain for a long period of time. So artificial intelligence has really helped to kind of speed those kind of processes up. And as we go forwards, I'm pretty sure we're going to see more artificial intelligence come out to kind of highlight pathologies. It's already there in other subspecialties. And in musculoskeletal imaging, it's just probably a matter of time before that happens. And we just have to learn to work with the industry companies and the vendors to ensure quality assurance, but also see how it can help expedite some of the work that we do, because we're all under pressure from time constraints, etc. So I say bring it on, and kind of working and embracing with technology is a really, really good way to kind of evolve our own careers.
Yeah, I think it's definitely a good approach to do it, and I know we've talked about it certainly on the ultrasound side. But from your side, Andy, do you see this as a way for you to help you with your move into retirement in terms of actually getting a break and a holiday? In terms of like, where do you see it? Because there is talk of people saying, right, well, do we need people to be doing imaging?
It's interesting, sir. I've recently, I think one of the first conversations you have with someone who you've met for the first time, and you say you're a radiologist, they all say, "Oh, so you're going to be out of a job in a few years' time." And as Shub says, I don't think that's going to be the case. I think but it is something that is certainly needs embracing. And what I see, the role for AI is rather than replacing the radiologist role, it's alerting or highlighting cases that may need more urgent attention. A good example of that is algorithms now, which will not, and this is not necessarily a musculoskeletal application, but it could come into where you've got large volumes of unreported work, such as the NHS, where some departments will have anything up to hundreds, if not 1,000 unreported scans that can be anything from 2 days to a week to a month old. It will highlight cases which perhaps have serious pathology on and bring them up to the top of the list, saying, look, this is not the report, this is not the diagnosis, but there's something abnormal on this, and it could be a serious finding, and it brings that and alerts the radiologist to pick that up next, rather than it languishing in an unreported list for weeks on end. Another thing which AI has certainly helped me get through more work quickly, and therefore I suppose give myself more time to relax, is a voice recognition. And again, when I started my radiology career, dictation was handled by a secretary who sometimes was even sat next to you, typing away as you were, reporting X-rays. And now we're at a stage whereby I can talk into a web-based app on my laptop, and it will not only very accurately transcribe and my dictation, it'll actually formulate it into a template report. It'll correct things. It'll sometimes make suggestions. And so AI is actually enhancing the vernacular that you end up using in your report, and putting it into a clear template, which improves our productivity. So yes, AI will, I think, help us with our practice, but certainly in musculoskeletal, I think it's going to be a long time before it's replacing us.
We see the massive growth with diagnostic ultrasound being used, from whether people are talking about butterflies, Clarius, some of the handheld ones. And so how do you interact with that in terms of if they're producing images on machines which would be not ones that I would assume you'd be using in your standard practice? Like, is it beneficial when a physio clinic has, say, got a scan? Like, how do you interact with them on that?
Yeah, so as you know, I'm involved heavily in education. We've kind of worked and collaborated together in the past around that. Education's big. I think with imaging and ultrasound in particular, there's not a huge amount of regulation out there really in terms of managing kind of the competencies of operators. There's lots of courses around that people can certainly attend and grow their experience at, but it's an imaging modality that one really needs to, in my opinion, perform and work on and practice with. So when I educate and teach on courses, I always say, look, this 1 day or 2 day course is great, but it's not going to be sufficient for your training. You really need to be utilizing this on a daily basis. If not for injecting, when you're seeing a patient and assessing them, get the transducer out and scan. Get a kind of build a memory bank of what's normal, because that's what we had to do in our training as radiology. And once you know what normal's like, then you can you find a bit more confidence in picking out the abnormalities. And as you said, there's various arrays of paraphernalia and equipment out there from an ultrasound perspective, from those fully cart-based systems to handheld devices. Basically, it's something for everybody. So if you're starting off you don't want to make a heavy financial investment, handheld devices can certainly work and support and supplement your own clinical practice and educational needs, because you can take that with you. You may even want to scan your own family members at home and look at anatomy. And ultrasound is wonderful. It has super spatial resolution, much better than MRI, actually. And a lot of people forget and I think that MRI is far superior. But when you're looking at things like tendons and the actual individual architecture of such things, or muscle fibers, ultrasound is a lot more better from a spatial resolution compared to MRI. So you do see really good detail. And of course, nowadays, mostly ultrasound is being utilized to help with intervening. So using imaging to help guide placing a needle where you need to place it. So you know that when you're treating somebody, you are injecting the product, the substance, whether that's steroid or whether that's HA or PRP. You use imaging to make sure you really do get the substrate in the right place, and also make sure you don't hit anything that you don't want to hit. So you don't want to be injecting into nerves inadvertently or into blood vessels. So the education is crucial. Practice, very important adage that we keep saying. And as you go through time, and your experience using the different ultrasound scans, you may find that somebody then escalates up to use a different type of scanner, the laptop-based systems that are out there that might provide a bit more power and oomph to the system with other kind of functionalities. And you just kind of really play with it. You can't really go wrong. You can't really go wrong with that.
Yeah, I think it's understanding where these sit within the realm of imaging, and that just because you've got a handheld device, that doesn't mean that you're doing the same job as what you guys are doing. And just for people to understand that, which I think the vast majority do, but that's where those educational days really help with it, to understand.
I think just to say on that, Andy, I think one needs to be aware of their kind of limitations as well. So, if you're not sure about something, or if you're not confident, then that's fine. And then you can escalate that. You can then consider a different imaging modality. It's the same in radiology. We may perform ultrasound and scan certain things or look for pathology, but if we're not confident, or if we're not sure, or even if we find something and we can't really characterize a lesion, and that could be a lump or a mass, then we might need to escalate and move it on to the next imaging modality. So the whole point is that ultrasound is certainly a very important facet within imaging, but it may not be the only imaging modality that we should be relying on to make diagnoses. There are other imaging modalities that can help to kind of supplement what we find on ultrasound, as well as prognosticate. So, we may find, colleagues scanning ankles and look for a tear of a ligament, let's say the ATFL. But then, that's not the only thing that can go wrong. And, if you do an MRI scan, for example, we know that MRI is far superior to assess the whole joint a bit more holistically. So you get to appreciate the ligaments maybe better, for sure, but also assess the joints and look for any other abnormalities, cartilage defects, etc., that might actually have an impact on that patient or on that player. So ultrasound, very useful, very important, very good starter for 10 to kind of utilize when you're trying to make those diagnoses. But in my book, I don't think it's the only thing that's available, and we should always be aware of that.
Arthrosamed's been talked about a lot within the sports medical field. Like, where is that up to in terms of its usage and efficacy?
That's a really, that's a very topical kind of subject, really, around the use of hydrogel, Arthrosamid, only really available in the private sector in the UK. A lot of athletes or retired athletes have been utilizing or making inquiries around the use of Arthrosamid, but also the general population, the non-professional athletes, where we're trying to manage arthritis, a degenerative wear and tear condition that all of us are going to have inflicted upon us to various degrees, depending on how we've lived our lives, whether it's occupational related or recreational related. I think the expense is certainly a major factor, but I do like learning the science behind how these kind of agents and substrates work. And if you delve deeper into the kind of science behind it, the whole idea from my perspective is to try and almost pick the winners, who's going to do well with this, as opposed to who's probably not going to do well. And therefore, as good as it might sound, this may not be the most appropriate thing for you at this moment in time. So, managing and selecting patients that may have pain or inflammation that's kind of more generalized due to their arthritic condition, typically those that may present with kind of inflammation around the lining of the joints, so-called synovitis, these hydrogels may well perform may well perform better. So it's selecting those cohorts of patients. Equally, there are patients that maybe might not be necessarily medically fit to have surgery or an operation like a joint replacement, and therefore using adjuncts and therapies like this, like arthrosamide, potentially may actually help buy some time for the patient, relieve their symptoms for a while, if not kind of not negate the use for surgery altogether. So there's no right or wrong answer really, and everything's very much about managing patients' expectations and having that kind of conversation, the two-way conversation or three-way conversation between the patient and their surgeon and the radiologist, and also the vendors actually, to kind of work out which would be the most appropriate treatment strategy perhaps for patients.
And like going back to a point you mentioned earlier on, where there's an MRI scanner on every corner now, like how do you understand quality? So in terms of the spec of the machine that OrthTeam have got, for example, like where does that sit in there? I can imagine that there's quite a variance of it, and they're massively expensive products.
Absolutely. I think that's something that maybe the layperson or somebody outside of radiology may not fully appreciate. If somebody says, I've had a scan, okay, you've had a scan, but there's so many variables within that as well. So within OrthTeam, amongst our radiology group, we do work together to try and identify what appropriate sequences we should be performing for the body parts that we image. And that's a decision that we make internally based on our experience and based on the pathologies that are referred to us, and try to make the best out of the super quality machine that we have. The scanner we have at OrthTeam is what's called it's a 3 Tesla MRI scanner. So it's a very strong, powerful MRI scanner that we have, and it also produces really good quality, clarity of pictures, and therefore we want to utilize the best bits of that scanner to provide the best possible image quality for us to then to make those interpretations. This can vary depending on other centers and different machines that are out there, different scanners in terms of the quality and how those sequences are acquired. So, the example I could give you perhaps is, one person has an MRI scanner at one site, another person at another site, but then there may be differences in the number of sequences that are being performed, or even how those actual sequences were performed to interpret the image quality. The way the images are taken, sometimes you don't get to see every single tissue being covered on a particular scan, yet they've had a knee scan or a shoulder scan. Whereas, we try to ensure, certainly at OrthTeam Centre, that whatever body part we image, we want to try and image that in its entirety and to the best of the scanner's ability and get the best quality. So that really then helps us when we're interpreting to make those imaging interpretations. On the outset, it can be difficult, though. If someone's going to get a scan, I wouldn't say that the cheapest available scan is going to be the right decision, nor the most expensive scan out there is going to be the right decision. But, these are the things that radiologists do, and maybe it's upon us to kind of highlight some of the kind of work that goes on really behind the scenes to ensure, working with our radiographer colleagues as well, that we get really good quality imaging, and not just about the scanner, but also the paraphernalia that comes with it. Most people that have had a scan will appreciate you have other bits and bobs attached to you, so-called coils, and paraphernalia that helps to kind of really highlight and hone in the signal that we're trying to achieve from some of our scanners to get the best quality. So there's a few different components that kind of make the MR scanner work, but we try to make sure we do the best.
Yeah, great. Look, guys, I'd have loads more questions, but we've come to the end of today's episode. So thank you very much for the insights. Really enjoyed it. And look forward to seeing you on the next episode of OrthTeam Unplugged.